Good afternoon, everyone, and thank you for joining us with our faculty development series. I have the pleasure to introduce Dr. Claudia Lora, who's going to talk to us about challenges in managing Hispanic Latino patients from a chronic kidney disease perspective. But let me give you a little more information about her background. She's associate professor in the Division of Nephrology in the Department of Medicine at the U of I, Chicago. She's also an associate head of faculty affairs in the Department of Medicine and medical director for the dialysis program at UI Health, board certified in internal medicine nephrology, specializes in chronic kidney disease, and there's a bunch of other things that are on her list of things. She completed intern residency and fellowship at the U of I and got a master's in science in clinical and translational research. Her research focuses on patient-centered factors related to health disparities. So what a perfect background to talk to us today about Hispanic and Latino patients. So please welcome Dr. Lora.
Good afternoon. Thank you for the kind introduction. I'm going to go ahead and jump right into our topic because we do have a lot to cover today. I'm going to try to pace us so that we can be done within the hour, including some time for questions. I have no disclosures related to conflict of interest. I do want to say that much of my research related to health literacy and acculturation is funded by a Career Development Award from NIDDK. Before we start, I just want to take care of a few housekeeping issues. And I want to start by saying that Hispanics, and reminding the audience that Hispanics are culturally, socioeconomically, and genetically a heterogeneous group and represent a wide variety of national origins and of social classes. So this talk by no means is intended to promote any stereotypes, and I will always encourage you to take a look at the individual in front of you and their unique history and their unique characteristics. I also want to acknowledge that undocumented Hispanics have faced like a unique set of personal and familial stressors that is not within the scope of this talk, so we are not going to be including those in the talk. In terms of brief definitions, when I refer to Hispanic Latinos, I'm referring to all persons of Latin American origin and living in the United States, unless we indicate. And for those of you who may be listening or watching that are non-clinicians, I tend to use abbreviations as a nephrologist very often. So in case I slip into my abbreviations, I want to tell you that CKD stands for chronic kidney disease, ESRD for end-stage renal disease, and GFR for glomerular filtration rate, which is a marker of kidney function. So that out of the way, let's start with a case. So we have a woman with diabetes and a creatinine of 1.4. You are a nephrologist today, and she has been referred to you for a creatinine of 1.6. She has been referred to your clinic for evaluation of this abnormality. The referral reads, she is Spanish speaking only, and she brings her daughter. You speak un poquito of Spanish, and depending on the circumstances, you get by with your skills. And so the question is, how does the literature guide the clinical encounter with this patient? As an outline to the talk, we're going to talk a little bit about the prevalence of ESRD and CKD in Hispanic Latinos. We're going to talk about the progression of CKD in this group. We're going to talk about factors related to health disparities. And lastly, we're going to spend some time addressing factors related to health disparities, about how to address these factors in the clinical context. Let's go ahead and jump right in by examining the incident rates of end-stage renal disease in the United States. So if we look at data from USRDS, that is the United States Renal Data System, we can see that the incident rate of ESRD among Hispanic Latinos has decreased throughout the years, whereas it's remained relatively stable among non-Hispanics. But what we can see is that the incident rate of ESRD in Hispanics compared to non-Hispanics is 32% higher. Similarly, the prevalence of ESRD among Hispanics is about 50% higher compared to non-Hispanics. And we can see that I have job security because the number of ESRD patients continue to increase. So that this health disparity that we're talking about, which is related to end-stage renal disease, it is a problem, is a growing public health problem, if you will. What about CKD? What is the prevalence of CKD among varying populations? So presumably before someone develops end-stage renal disease, they will have had some level of chronic kidney disease. And data from the National Health and Nutrition Examination Surveys, or NHANES, show us that in 2018, the prevalence of CKD among Hispanic Latinos was 11.9%. Data from the Hispanic Community Health Study, or the study of Latinos, which is the equivalent of the Framingham for the US Hispanic population, shows a very similar prevalence in CKD. And I would be remiss if I don't tell you that if we look at different Hispanic backgrounds, for example, Puerto Rican versus Mexican versus Dominican, the prevalence may vary a little bit, which underscores the heterogeneity that I spoke about at the beginning of the talk. But briefly, the overall rate of CKD among US Hispanics is approximately 11 or 12%, compared to about 15.7% in non-Hispanic whites. That is different from what I just told you, right? Higher rates of ESRD, however, lower rates of CKD. And here's a graph that really depicts that when we look at the relative prevalence of CKD in Hispanics compared to white, it's much lower. And yet the stark difference between the ESRD rates. So is it that there are fewer people with CKD, but somehow this smaller pool of individuals is progressing more quickly to ESRD? Well, let's take a look at progression, and I think that does in part explain some of what we're seeing here. So in terms of progression of CKD in Hispanic Latinos, we're going to start by looking at data from KAISER PERMANENTE, which followed a group of individuals with chronic kidney disease for approximately 6 years. And what we can see is that when we use whites, non-Hispanic whites, as the reference group, and after adjusting for several factors, including socioeconomic status, comorbidities, etc., we can see that the risk for progression to ESRD is 33% higher among Hispanic individuals compared to non-Hispanic whites. Data from the chronic renal insufficiency cohort study, we took a look at this more recently in the chronic renal insufficiency cohort study, which is a multi-center study which is focused on examining risk factors for progression of CKD, and it is sponsored by the NIH, and the University of Illinois is one of the primary sites for this study. But data from the CRIC study also shows a very similar pattern when we see the crude rates of progression of kidney disease defined as either development of ESRD or the composite outcome of ESRD or 50% eGFR loss. We can see in green much higher rates among Hispanic Latinos compared to non-Hispanic whites. So we went ahead and looked at this a little bit more closely, and I'm going to show you a very busy table. And for that reason, I'm just going to highlight in red what I want you to look at. And we can see after adjusting for several factors, including sociodemographic and comorbidities, the risk for the composite outcome of ESRD or 50% loss in GFR is 90% higher among Hispanics compared to non-Hispanic whites. And the same thing is true if we just look at the outcome of end-stage renal disease, with the risk being 81% higher. Now, if I'm fully transparent, I have to tell you that once we adjusted or included proteinuria in the model, that increased risk was still present, but not statistically significant. And what does this mean? It means that we need to do more research on the topic. It's possible that Hispanics intrinsically have more proteinuric kidney disease, or that perhaps there are differences in responses to ACE inhibitor as we adjusted for use of ACE inhibitor in this. But again, more research is needed in this area. But I do want to highlight that if we look at the crude rates from the CRIC study, and if we look at the KAISER PERMANENTE study, I think it's very clear that we do indeed have a smaller pool of individuals with CKD that is progressing more quickly to ESRD. So let's go ahead and start looking at what are some of the factors that underpin this health disparity. And I want to start by showing you this model, which we published recently in the American Journal of Kidney Disease, which is based on the lifespan biopsychosocial model. And basically what this model suggests is that outcomes in kidney disease are related to psychosocial factors, biological factors, healthcare access that result in differences in behaviors, in risk factor control, and that all of this occurs in the greater sociocultural context, which includes socioeconomic status, language, and culture. So what I want to do, because it's absolutely impossible to cover every single element of this model within an hour, is focus on a few selected ones, particularly the ones that are related to my research and sort of the ones that are more obvious. So we're going to start with biological factors, because often when people talk about health disparities related to ethnicity, one of the first things that come to mind possibly is some genetic differences. So what do we know about genetics and CKD? Very little. But recently, within the last decade, we learned about the APOL1 gene and how there are actually two variants, the G1 and G2 variant of the APOL1 gene, which are found in individuals of African descent and actually confer resistance to Trypanosoma brucei, similar, I would say analogous to sickle cell disease, right, in the gene related to sickle cell trait. These variants, the G1 and the G2 variants, have actually been associated with increased progression of kidney disease. We could see data again from the CRIC study that when we have that individuals that have either one or two mutations are at increased risk of progression to the ESRD or to loss of kidney function, and that the risk is highest among individuals that have two alleles, the G1 and G2, and that this difference is seen among diabetics and among non-diabetics, so that this genetic association has been very well described in the literature as it relates to Black Americans. So what about Hispanics? Well, I already mentioned that Hispanics are very heterogeneous, and that includes heterogeneity in terms of genetic profile, because the genetic profile of Hispanic Americans, given the history of Latin America, includes European ancestry, African ancestry, as well as Native American ancestry. And if we look at data from the SOUL study again, we can see that approximately 15% or so of the Hispanic participants in the SOUL study, which is actually a very diverse cohort in terms of Hispanic backgrounds, with good representation from Cubans, Mexicans, Puerto Ricans, Dominicans, and Central Americans and other Hispanics. We can see that approximately 15% of individuals in the SOUL study have some degree of African ancestry. And that if we separate individuals based on Caribbean origin or mainland Latin America, as is expected based on the history of the Caribbean and the fact that slaves were brought into the Caribbean to work in the sugarcane fields, we can see that approximately 25% of Caribbeans have some degree of African ancestry compared to 6% of mainlanders. And so the investigators in the study then went ahead and took that African ancestry and took it to the next level to try to look at the APOL1 gene that we mentioned. And what we can see here is that the APOL1 gene in a cohort of Hispanics in the SOUL study was indeed associated with a 3.2 increased risk of CKD as defined by albuminuria or decreased GFR. And if you look at just the Caribbeans, the risk was around 2.9, and this was statistically significant. In addition, data from the SOUL study has also recently found an association between increased albumin excretion and Native American ancestry in Hispanics, which has actually been attributed to a specific genetic variant listed here, the A allele, that is actually found among Pima Indians. So we can see that future studies are really needed to see if these genetic variants, so these are all associations, right? These are looking at cohort studies. We see an association between these genes and CKD, but future studies are really needed to see if there's any association with the development or with the progression of kidney disease in these genetic variants. Now I want to move on to the sort of larger sociocultural context with a focus on socioeconomic status and language and acculturation. And we're going to go ahead and start with socioeconomic status. And the association between low socioeconomic status and kidney disease has been extensively described. And I'm here showing you a meta-analysis that is showing the association between low socioeconomic status. Here is sort of the overall risk here between low socioeconomic status and incident renal failure. So this is something that has been absolutely well described and that most nephrologists can talk about somewhat eloquently. So what does the socioeconomic status of Latinos look like? Well, if we look at poverty rates, we can see that in 2019, 15.7% of US Hispanic Latinos live below the poverty line compared to 11.6% of US Hispanic whites. So likely these differences in economic status contribute to differences in disparities in CKD. What about language and acculturation? So let's take a look at language first. So if the US, if the number of Spanish speakers in the US were a country, they would actually be the 4th largest country in Latin America. So 41 million people in the US speak Spanish as their primary language. And of those 41, about 16 million actually have low English language proficiency. So 60 million people with low English language proficiency, what does that mean in terms of their healthcare and their healthcare outcomes? I want to show you data from one of my friends, Dr. Fernandez, who works out in California. And she's basically looking at the communication between physicians and individuals with limited English language proficiency compared to those that are proficient in English. And if we just compare those that are proficient in English to those that have limited English language proficiency, we can see that those that have limited proficiency are more likely to feel that as though they're being treated poorly because of language, and they're also more likely to feel that the MD was not listening to them. When we take a look at individuals of limited English language proficiency and how they're paired up in terms of a healthcare provider. So here in this column, we see an individual of low English language proficiency that is paired up with a language concordant healthcare provider or physician. And in this column, we see individuals of low English language proficiency that are paired with a language discordant healthcare provider. And we see that those that are seeing language discordant healthcare providers have higher, are more likely to report lack of trust in the MD, are more likely to report feeling treated poorly because of their language, and also more likely to report that they felt that the MD was not showing respect for them. Therefore, language discordance between a patient and a healthcare provider leads to dissatisfied patients. We can say that. But what does it mean in terms of health outcomes? Well, I'm going to show you briefly a paper looking at a language concordance and glycemic control. And what they did in this study is that they actually took patients that were in language discordant, that had a language discordant physician, and they changed them to a language concordant physician. And there were some other changes made to sort of act as the control, but let's focus on the individuals that switched from a language discordant care provider to a language concordant healthcare provider, and that we could see that there was quite an increase in the percent of patients that achieved glycemic control. Before, when they were with the low discordant, here we are, quite low, and much higher here when they were with the language concordant physician. Indeed, the investigators observed a 10% statistically significant improvement in glycemic control in the individuals who switched to a language concordant physician. There was also a statistically significant improvement in LDL. So as you can see, language proficiency and concordance do impact these intermediate health outcomes. In this case, we're looking at glycemic control. So what does that mean? Well, does that mean that maybe all physicians should speak Spanish? Well, we're going to talk about that a little bit more, and obviously that's a very lofty goal. But let's go ahead and switch from language to culture, and we're going to focus on the concept, on the construct, excuse me, of acculturation, which is defined as the process by which individuals adopt the attitudes, values, customs, beliefs, and behavior of another culture. The idea is that an individual goes from their original culture to the new culture, and that's by being in this new culture, they will be changed. Their beliefs will change, their attitudes will change. Well, we all know that that's not true, that the individual would not be changed 100%, right? And that there's likely a continuum along which they will fall. Often we tend to retain elements of our original culture, right? So the idea is that this continuum is measurable, and that depending on where you fall in this continuum, that it may have outcomes related to your health. So in terms of acculturation, there's extensive literature examining the role of acculturation in health. And it turns out acculturation can be both beneficial and detrimental to your health. So the pros of higher acculturation are that individuals with higher acculturation are more likely to use preventive health services, more likely to have health insurance, more likely to have access to health care, increased adherence to treatment, higher socioeconomic status, greater exercise, greater leisure time activity. The con, or the negative side of this, is that individuals with higher acculturation have higher obesity rates, more likely to have increased fat intake, increased fast food consumption, decreased intake of fruits and vegetables, increased risk of smoking, increased alcohol consumption. So where does the balance fall? You can see that the lists are pretty similar in terms of length of what's positive and what's negative. So where does the balance fall in terms of health? Well, the literature would suggest that a higher acculturation may be actually detrimental to your health. And again, I want to emphasize that we are not here to promote any stereotypes. So under no circumstances am I suggesting that the American culture is detrimental to health, right? But this is what the literature shows us. In the Hispanic community health study, or the study of Latinos, higher acculturation was associated with increased risk of cardiovascular risk factors. Similarly, in NHANES, lower acculturation was associated with lower cardiovascular risk factors. What about in terms of mortality? That has also been described in the San Antonio Heart Study. Both diabetics and elderly individuals with higher acculturation had an increased risk of cardiovascular mortality. So it is possible that the balance of acculturation falls towards it being detrimental to your health, as I mentioned earlier. But what about, and likely there are many factors to explain this, so I think that sort of pinpointing culture as the only culprit behind this, it would be a very limited view of what's happening. But what about acculturation in terms of kidney disease? Well, this has been examined. This is a study looking at individuals by language and their GFR, or their percent kidney function. And what we can see that the reference group here is individuals that are Spanish speaking. And what we can see is that those individuals that spoke exclusively English had actually lower GFR than those that spoke Spanish. But what was really interesting, which is sort of consistent with the literature, right, that higher acculturation, English being a marker, a proxy of higher acculturation. But what was most interesting is that those individuals that spoke a mix of English and Spanish had even lower GFRs than those that spoke mainly English, which really highlights the complexity of acculturation. And it's possible that these individuals are falling somewhere in the middle of that acculturation spectrum that I showed, where they have perhaps gained some of the detrimental effects of acculturation and lost some of the beneficial impacts of sort of lower acculturation, or their original culture, if you will. We also looked at this in the Hispanic, in the study of Latinos, or the SOUL study. And what we found is that we found the opposite, actually. We found actually no association between the two acculturation subscales of the short acculturation scale for Hispanics, with the exception of one group, which was the older Latinos or Hispanics. Those greater than age 65, the language subscale was associated with worse kidney function. So those that have lower language subscale scores, or lower acculturation, if you will, actually had increased risk of CKD, which again underscores the complexity of acculturation, but certainly very interesting signals that culture do have an impact in terms of kidney disease and kidney disease outcomes. Next, I want to move on to the next sociocultural context, which is health literacy, which has been one of my biggest focus in terms of research. So what is health literacy? Health literacy is the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions and its health toll. What does that mean in a more tangible explanation? Well, health literacy is generally divided into measures of either being proficient, intermediate, basic, or below basic. And again, to make it more tangible, when we talk about an individual having below basic health literacy, they have 67% probability of being able to identify what is permissible to drink before a medical test based on a set of short instructions. When we talk about an individual being proficient in terms of their health literacy, they have a 60% probability of being able to find the information required to define a medical term by searching through a complex document. So very big differences between below basic and proficient health literacy. And what is the prevalence of limited health literacy? Well, before I show you that, well, I'm already showing it to you, but before we discuss the numbers, I want to make sure that I emphasize that health literacy is not a measure of intelligence. It is also not even a measure of educational attainment, although often correlates well with educational attainment. And again, I want to keep saying throughout the talk that I'm not here to create any sort of stereotypes, but what we can see underrepresented minorities such as non-Hispanic Blacks and Hispanics, the prevalence of below basic health literacy is higher compared to non-Hispanic whites. And more concerning, when we look at the proficient health literacy among Hispanics, it's only approximately 4%. So health literacy actually has also been well studied in the context of health outcomes, and it has been associated with knowledge, behaviors, and attitudes related to health that result in negative health outcomes, low health literacy, excuse me. So low health literacy has been associated with decreased disease knowledge, decreased use of preventive health services, decreased adherence to medications, decreased self-management, and decreased self-reported health. What about kidney disease? What does health literacy look like in kidney disease? Well, we actually examine health literacy in the CRIC study, and this is the baseline characteristics of the cohort. And we can see that approximately 83% of the cohort had adequate health literacy, and about 17% had limited health literacy. So when we looked at this at baseline, some of the interesting findings that we saw is that individuals with limited health literacy had higher blood pressure, they had lower GFR, percent kidney function, and they had more proteinuria. And if you are a nephrologist, the two things that you worry the most about in your patient, because they are two of the strongest risk factors for progression of kidney disease, it is blood pressure control and level of proteinuria. And so what this sort of indicated to us is that these individuals with limited health literacy were likely at increased risk of progression of their kidney disease. So approximately 3.5 years later of being follow-up, we decided to take a look at this. And what we found is that indeed the crude rates of progression of kidney disease were much higher among individuals with limited health literacy, pictured here in the light green, compared to those with adequate health literacy. And this was true of the composite outcome that we mentioned before, 50% decline in GFR or ESRD, or the single outcome of ESRD. We also see increased atherosclerotic events, and we see increased death as well with health literacy, as has been described, with low health literacy, as has been described in other populations. We also see an increased rate of hospitalizations among this group. So these are crude rates that I'm showing you. Once we adjusted for several factors, including age, gender, race, socioeconomic status, and comorbidities, etc., the only two that remained statistically significant were increased risk of atherosclerotic events and increased hospitalization risk. So clearly, low health literacy identifying individuals that are at high risk for these two. Likely, we didn't see statistical significance in the CKD outcomes because the follow-up was not long enough. And so that's something that we will revisit in the future. Moving forward, let's go back to our conceptual model and let's look at access to healthcare and limited access to healthcare. So if we look at census data, we see that in 2018, 21% of Hispanics adults reported not seeing a doctor due to the cost of seeing a doctor. So that we know that access to healthcare is limited in Hispanics. And if we compare that to whites, we see that in whites this number, while still significant, 13, was lower than compared to Hispanics. We also see that this is likely a result of the high rates of uninsurance among Hispanic individuals. We can see that in 2020, 16.7% of individuals of Hispanic Latino ethnicity were uninsured, compared to only 5.2% of non-Hispanic whites. I included 2012 census data here as well, because it's interesting to see that there was a decrease for both groups in terms of the percentage of individuals that were uninsured. And this is likely a result of the implementation of the Affordable Care Act in 2014, which underscores the role that policy plays in addressing health disparities. But insurance is only one aspect of it, right? The idea is also about seeking, having a usual source of care. So ideally a primary care provider that is coordinating your care. And we know that individuals that are uninsured compared to those that are insured are much less likely to report having a usual source of care. So they're more likely to report not having, in this case, a usual source of care, which is what we're seeing in this figure. What does this look like for the CKD population? Well, this has actually been looked at in the KEEP, or Kidney Early Evaluation Program, that is funded by the National Kidney Foundation, which is basically a nationwide health screening program that runs health fairs throughout the United States and identifies CKD in different individuals. And data from KEEP here, picture here, shows us that approximately 7.4% of 7.4% of Hispanics report with CKD report finding it extremely difficult to obtain medical care, and 16.3% to somewhat or moderately find it difficult to obtain care. And even more concerning is that 11% of Hispanics with CKD are receiving no type of care, at least at the time of the screening process. We actually examined the importance of a usual source of care in CKD in the CRIC study among individuals with mild to moderate kidney disease. And we found that individuals that had a usual source of care, such as a clinic, as opposed to individuals that went to an urgent care or to an ER to obtain their care, were less likely to have, to develop, these are CRU rates again, to develop ESRD, to have atherosclerotic events, incident heart failure, all-cause death, and cardiovascular death in particular. So that access to care, and particularly having a usual source of care, has important implications in terms of disparities in CKD. So let's talk a little bit briefly about adequate control of risk factors. And I'm not going to spend a ton of time on this because I think that this is very well known and described. And I do want to make sure that we have time in the end for questions and that we spend some time on how to address these issues clinically. But the three sort of big risk factors for CKD development and for CKD progression are obesity, hypertension, and diabetes, with hypertension and diabetes being the two top causes for ESRD in the United States. So what does this look like in the Hispanic population? Well, as you can see, based on census, on NHANES data, the prevalence of obesity among Mexican American adults is higher in both men and women compared to non-Hispanic whites, particularly when we look at Mexican American women. In terms of hypertension, this is data from the SOUL study. We actually see that the prevalence of hypertension is not that different between non-Hispanic whites in NHANES and Latinos, Hispanics in the SOUL study. However, Hispanic Latinos were less likely to be aware of their high blood pressure, less likely to be treated, and concerning on all regards for both non-Hispanic whites and Hispanic whites, the rate of blood pressure control were quite low in both groups, only 56.3% among whites and only 37.3%, considerably lower among Hispanics. We actually did the same examination looking at individuals with only CKD and had very similar findings. What about diabetes? Well, for the sake of time, we'll only take a look at this column, and we can see that the overall prevalence of diabetic among Hispanics compared to non-Hispanic whites is higher, 15% versus approximately 12%. But what about the care of diabetes among Hispanics compared to whites? And here we could see data comparing cardiovascular risk factor control among diabetic Hispanics compared to whites. And by cardiovascular risk factor control, I mean risk factors for CKD and CKD progression, because they are the same, right? So we could see that they looked at glycemic control, blood pressure attainment, and LDL attainment or cholesterol control. And we could see that Hispanic men were less likely to achieve glycemic control and less likely to have achieved LDL control, and less likely to have achieved control of all three of these risk factors. In women, the only thing that was significant was actually glycemic control. So among diabetic Hispanics, the risk factors for the cardiovascular risk factors, which again are the same risk factors for CKD development and progression, we see some differences based on ethnicity. So having sort of established these many levels of disparities in terms of CKD. How do we address these factors in the clinical context? We're going to spend some time doing this. And my research, as I said, has focused on acculturation and health literacy. So this is the focus of the data that I'm going to show you. Before I do that, I want to point out that language, acculturation, and health literacy are intrapersonal factors. And according to the sociological model of disease, health disparities are really a result of a very complex interplay between intrapersonal, interpersonal, neighborhood, and environmental factors and systemic factors, right? So that in order to truly address health disparities, we need to address them at every one of these levels. And for the sake of this talk, we're sort of limiting ourselves mainly to the interpersonal factors. Let's start again with language. Excuse me. A brief reminder that 16 million individuals have limited English language proficiency. And if we look at what the patient experiences in accessing adequate health care, in order for a patient to access adequate health care, first they need to receive adequate healthcare, excuse me, first they need to be able to access it, right? So in order to access healthcare, it needs to be available. The individual needs to have knowledge of the availability. They need to be able to meet the costs or have insurance. They need to be able to complete the form and read the signs that lead them to their healthcare, right? Once they get to the healthcare provider encounter, an individual needs to be able to provide information, answer questions, ask questions, process that information, and then it's time to go home and practice self-care, right? Which you have to remember the instructions, have understood the instructions, implement them, you need to be able to read and understand labels, and you need to be able to follow anticipatory guidelines. For example, if your glucose is X, you need to give yourself X amount of insulin, right? So you can imagine that individuals with limited English language proficiency can encounter barriers all along this trail, as can individuals with limited health literacy. But we're going to focus first on English language, and I want to remind you 16 million Americans have limited English language proficiency. And earlier I alluded to some individuals suggesting that maybe all physicians need to speak Spanish. Again, very high, lofty goals, but maybe Spanish 101 can become part of the medical curriculum. I think that's going to be unlikely, but that brings us to the point of the use of interpreters. And there is vast literature regarding the benefits of using interpreters. We're going to take a focus here on the right-hand column first, and we can see that bilingual providers or using appropriate interpreters or medically trained interpreters, when we use these, patients have the highest level of satisfaction. They have increased use of screening services, preventive screening services, possible longer duration of clinic visit, implying better communication or more extensive communication, at least with a physician, and more office visits and prescriptions written filled with implications regarding follow-up. On the other hand, using no interpreter or using the ad hoc interpreter, which is the family member that came in or the MA that we pulled into the clinical room to translate for us, actually is associated with lower patient satisfaction, misinterpretation or omission of questions and information, more likely for errors to be committed with potential consequences, higher risk of not mentioning medication side effects, ignoring embarrassing issues, so those not being addressed, misinterpreted or omit up to half of the physician questions, more medical tests, higher costs, risk of hospitalization is increased as well. Patients that were no interpreters used report are more likely to self-report not understanding their diagnosis. So the point is that in the medical encounter, we need to absolutely avoid the ad hoc interpreter, or of course, not having an interpreter is even worse. So beware of the doctor that speaks un poquito, right? So having a medical interpreter in the clinical encounter when dealing with individuals with limited English language proficiency is key. What about culture? Well, normally about 10 years ago, I would have shown you this slide, which is the beliefs and attitudes of Hispanic that could potentially impact their health. And I'm going to quickly block that slide because I don't even want you to read that. Because the idea now is that this is what we would call cultural competence before. The idea is to switch to a paradigm of cultural humility. And what is the difference between cultural competency and cultural humility? In cultural competency, we have discrete endpoints. The idea is that you can learn the background of a culture, like what are the beliefs, what is the religion, what is the language, that I can learn who you are. And the idea is to switch to the concept of cultural humility, which is one of self-reflection, including reflection on our own implicit biases. It means that we are lifelong learners because we need to take every patient as an individual, which is why I keep harping on, I'm not here to promote stereotypes, right? Instead of asking questions of the patient, letting them tell you their story. The concept of cultural humility is that you can teach me who you are, and that every patient is going to be a little bit different. So if we take a look at Mrs. AJ, she is more than a 73-year-old Puerto Rican American with diabetes. She is also a mother, a grandmother, a wife, a sister. She's Baptist. She's a retired school teacher, a resident of the Tri-Taylor area, afraid of needles and of spiders. And only she is truly qualified to tell you the uniqueness of the intersection between her race, her religion, and all these other things that are measured with her identity, and the relevance of that intersection to her relationship to her illness and to her perception of her own wellness. Cultural humility, again, is something that we could talk about for an hour, and I would be happy to come back and talk about that. But, you know, I think that if I at least give you the idea that we cannot learn who a Hispanic patient is without actually meeting that individual, I have done a good service in terms of your clinical encounters. And I'm sure many of you already are doing this. Now, what about health literacy? Well, in order to be able to address health literacy in the clinical encounter, you first have to recognize who has limited health literacy, right? And here are quite a few tests that are done in the research setting, but not so much in the clinical setting. We don't have 20 to 25 minutes to measure health literacy in a patient, and these are not really accessible in the clinical encounter. So the key is to recognize who are the individuals that potentially have limited health literacy. And this not only applies to Hispanic Latino patients, it applies to any patient that you have, right? And those are looking for those behaviors that may indicate that someone has limited health literacy. For example, are they frequently missing appointments? Are their registration forms incomplete? Are they non-compliant with their regimen? Are they not following through with the lab test that you ordered? Are they saying that they're taking their medication, but the lab results are not really showing that? Look for responses regarding receiving written information. So I forgot my glasses, can you read it for me, or I'll read it when I get home. There's often so much shame associated with admitting that one is illiterate, right? So look for sort of these clues as well. Responses regarding their medication regimen. So if you're talking to someone and they're not really able to name their medications or explain why they're taking that medication or explain when they take that medication, likely that person has limited health literacy. And we do have a single question that has been validated as a screening tool for identifying individuals that may have limited health literacy. So if you ask a patient, how confident are you filling out medical forms by yourself? And if they respond somewhat or a little bit or not at all, that individual is likely to have limited health literacy. So let's go back to our lady with Mrs. AJ with diabetes and the rise in creatinine. We can imagine that we can make changes for her anywhere along this trail of the healthcare experience for the patient. So we'll start with access to healthcare. It's important to make the access to healthcare be easy. So when someone calls for an appointment, it's important that they make sure they reach a person. You can imagine how frustrating it is for us when we call somewhere and we get a voicemail. Imagine how much more so to someone who has limited English language proficiency or low health literacy. It's important to give very concrete directions for how to get to the office, to help them prepare for their visits by maybe telling them what they need to bring, what forms they'll be filling out to bring their medications in. And around the office and the healthcare system, of course, using clear and easy to follow signs, ideally in various languages. When filling out forms, it's important to be able to offer patients the assistance to complete those forms, to only collect essential information, because the more complex these forms are, the more overwhelming they become, to use the preferred language in the form if possible as well. In terms of the medical health the medical encounter, I already mentioned about how to assess health literacy, but this is true for every patient and probably for me during this talk, which is slow down, right? We also want to make sure we use plain non-medical language, use formal interpreters, simplify instructions, use visual aids, confirm understanding by asking to repeat instructions, and then also the concept that I briefly explained, which is to exhibit cultural humility. In terms of self-care, we want to make sure we're doing culturally appropriate dietary education. For example, in kidney disease, it's very often that we're giving education regarding hyperkalemia and foods that are high in potassium. And often we're giving these lists that don't include Hispanic foods, for example. When referring to ancillary tests, it's more to give simple instructions, have office staff review the material with the patients, provide directions to the site of referral, maybe have someone in your business office help with coordinating insurance, assessing social support. I don't know if you noticed in our conceptual model, which we didn't cover that part of the conceptual model today, but that social support is a potential buffer to sort of the negative impact of limited health literacy, of low acculturation, right? If you have someone that can help you remember how to take your medications, why you take them, you know, that certainly goes a long way. So involving family members, possibly promoters that help promote in the care of the patient. And hopefully I have convinced you of the importance of an early referral to a nephrologist as well. And so again, I'm just going to go back here. We have kind of reviewed where along these experience of healthcare we can make changes for our patient. And I'm sure that those of you that are watching or listening to this right now are able to come up with a ton more examples than I can. But essentially, this concludes my presentation for today. So in conclusion, Hispanic Latinos are disproportionately affected by end-stage renal disease. There are modifiable and non-modifiable factors that underpin these disparities. And this disparity should be addressed in the clinical context, but ultimately requires multiple level change at the system level. Thank you very much. Are there any questions?
So thank you so much for a very interesting discussion and kind of enlightening in my regard. I didn't realize all the associated factors and those things. Let's go ahead and open up questions either via chat, or since I think we're a fairly small group, we probably could just take questions verbally as well.
No questions. I think that's a lot to process, right?
Well, we'll give them a minute or two to warm up to questions. So, you know, I guess, you know, I look at this as you talked about social determinants as being an issue, and that is such a broad-based issue. Any suggestions about how one would approach that, or is it just on a, you know, higher level?
Yeah, I think a lot of it is at a higher level. It's really at the system level. And we, you know, there's so much that I didn't touch upon, because even sort of the neighborhood context and the availability of food and, you know, the number of fast food restaurants in a neighborhood, there's so much of this topic that obviously we can't cover in 1 hour, but it is ultimately at the higher level that it needs to be addressed. But I think as clinicians, if we have an understanding of sort of who are the individuals that we're seeing that are particularly high risk for poor outcomes, I think that goes a long way in sort of involved in having a more involved care with that patient, you know, recruiting family members, recruiting staff to help them, etc.
You know, on a related note, you had talked about English proficiency as a factor in chronic renal disease. I just wonder if we provided language classes, would that actually change? Is there any literature to show that teaching those folks how to you know, be proficient in English changes things?
There isn't any literature, and in fact, even when I was reviewing the literature for the use of translators in the context of CKD and echo, I'm sorry.
We have an echo. If you could all turn off your microphones, or
So, and even when I try to read the literature of the impact of translators in CKD, there's very little out there. So that's the next level of research, right? Is sort of what are the interventions that can address these factors that underpin health disparities.
And with the the law and the that we have to have official has it or not? I think Newton's got to mute. Newton, it's you. So I'm just curious, Claudia, was there a bump or not? I mean, or even with the information we share, the patient comes in the emergency room, they come home, they get all the packets, and it's in Spanish. Can they,
yeah, I don't think that there's data showing the global impact of sort of that policy that translators need to be available at all times, right? I don't know that there is global data related to that, but there's certainly extensive literature that was compelling enough to support the use of translators and to having them be there. But again, another area that needs to be examined.
Yeah.
Right? So what was the impact of that change?
Amazing.
I think there's a question in the chat.
Right. Please go ahead and respond to that if you'd like.
So information regarding the efficacy of online translation services, very little. We do know that telephone and video work. We know that Google Translator is very inadequate, so you cannot use that. So really, both video and telephone and in-person translation are good, are adequate in the encounter. How can we make sure our trainees and teachers incorporated? Yeah, I think that it's really coming down, which I think we're moving towards that, about having the medical curriculum include, right, addressing the concept of health disparities and the factors that underpin it, having the medical curriculum address cultural humility, having and this is a topic that I don't even want to touch with a 10-foot pole, but I think that all of us these days are much more aware of how systemic racism impacts health, and sort of having the medical curriculum address systemic racism. Indeed, at UIC, we actually have an anti-racism course, which all the M1s and the M2s participate in. Let's see, what else? How can we make sure? Oh yeah, so I think those are all the questions in the chat, and my sister Anna saying hello. Any other questions?
I think we should invite her back and make it required.
I was talking to Christina before the talk started, and I said, I'm really not doing the topic justice. I think that there's so many of the points that I made that could take more than an hour. So I'm more than happy to come back and talk on any of those subjects if you guys want me to.
So I have another question, and I don't mean to monopolize the question. So if anyone else has it, please feel free. But one of the important things is, cultural understanding, cultural sensitivity. And the struggle that I have is that, you have a diverse population you care for, or most providers have a diverse population. So how can you have cultural understanding of, Latinos and Asians and South Africans and, just the gamut, or is there a different approach?
Right, and the answer is you cannot. And that's why we're moving away from that paradigm of understanding culture to cultural humility, which is I can never even presume to be able to completely know your culture, so I want to know about you. And I think that that's relevant to patients regardless of whether we're part of the same culture or not. And that's why I think that paradigm shift was essential, really.
And I think the other thing is to check it out, like, well, I don't know how you handle it, or your family handles it, or what's the best approach in your circumstance, just something to show some sensitivity to what may be different than what we're all used to.
Yeah, and I think the limiting sort of the limiting step in all of this is the time that it takes in the clinical encounter to truly get to know your patient in depth. And again, underscoring the importance of system changes, right? That perhaps these 15-20 minutes that we're given to spend with patients and the productivity that is expected of us may not be realistic to truly provide adequate care.
Well, I'm going to give the group one more chance to ask a question before we conclude. Well, hearing none and seeing none in the chat box, it doesn't mean that we don't have interest in this topic. It sounds like there's a lot of interest. And so I do want to thank you, Dr. Lora, for speaking to us today and for providing a key component to our education and faculty development as well. And I want to thank all the participants and have a great afternoon.
Thank you very much for having me. Thank you, everyone.